Good morning, my dear friends. It is indeed a wake up call for everybody to understand that all is not lost when something goes wrong, be it life, elections, or surgery. There may be many a slip between the cup and the lip, but that does not mean that we should abandon the process of having our coffee. Similarly, in surgeries, we are likely to come across many complications, but a wise man is he who salvages the situation even under grave circumstances and provides for the best
Let's
possible
discuss a few
visual
clinical
outcome.
case scenarios wherein a posterior capsular rupture occurs.
The first video will be Dr. SUVIRA JAIN's video, in which she will be talking about posterior capsular rupture, which is something which we all dread, and the judicious methods of handling a PC rupture and the many attendant complications along with. Ladies and gentlemen, I present to you Dr. Suvira Jain's video.
Let's discuss a few clinical case scenarios wherein a posterior capsular rupture occurs during different stages of phacoemulsification. Let's start with the first case. This patient presented with a PCR intraoperatively towards the end of nucleus management. One small fragment has dropped down into the posterior segment as well. Let's see how we manage this case. Prior to withdrawing the phacoprobe, I first perform a viscofluid exchange. There seems to be no disturbance in vitreous, so I actually attempt to remove the cortex with the bimanual irrigation aspiration. At any point during this step, should I find any vitreous disturbance, I would move to using a cutter to first cut the vitreous in the cut IA mode and then remove the cortex in the IA cut mode. A viscofluid exchange is performed prior to swapping the hands, prior to removing the rest of the cortex. I then proceed with the removal of the rest of the cortex. I have some doubt about whether or not there is some vitreous disturbance, and so I inject some triamcinolone acetonide into the anterior chamber to look for it. A small check limited anterior vitrectomy is performed in the area of the pupillary plane overlying the PCR. After enlarging the opening to 3.2 millimeters, you will see now how a 3-piece IOL is placed with care and caution within the safe confines of the ciliary sulcus. Once the leading haptic is in the sulcus, watch now how the trailing haptic is slid into its place in the ciliary sulcus. With the lens now stable, the excess viscoelastic is washed out of the anterior chamber. And finally, the wounds are hydrated, and this is the end result that we have achieved. In the next case, we'll see a PCR occurring during irrigation aspiration. So this patient who presented to us with a hypermature cataract had an uneventful nucleus management. We performed a direct chop technique, and each of the fragments was suitably downsized and emulsified. We then proceeded with the bimanual IA. The left half of the cortex was removed without any issues. Let's see what happens during the second half of the irrigation aspiration. Let's get to the point of removing the cortex at this 11 o'clock position. At this point, While attempting to remove the cortex, the surgeon accidentally holds on to the PC. This tear is once again visualized under a higher magnification. At this point, there is no disturbance in the vitreous. So the surgeon then goes back in with the IA with care and caution and aspirates the last bit of the cortex. Since there is no vitreous disturbance under the irrigation itself, the surgeon then holds on to the tear in the posterior capsule with the help of an intraocular forceps, and this tear, as you can see, is converted into a stable circular opening. We now have a small, circular, stable opening in the posterior capsule and no vitreous disturbance. The surgeon now proceeds to implant a single-piece monofocal IOL within the capsular bag. With the hydration of all the incisions, we now come to the end of this surgery, and this is the end result that we have achieved. The next case is a patient with a posterior polar cataract who ended up with a PCR very early on in the surgery. Here's a patient with a typical posterior polar cataract. Following the rexes, we proceed to do a hydrodissection. A successful hydrodissection is performed, and then, without further manipulations, we proceed with the nucleus management. But look what happens as soon as I go in foot pedal 2. The posterior capsule gives way. In this scenario, you've got an entire soft nucleus in the eye and a posterior capsular rupture. So how do we go from here? A viscofluid exchange is performed, and then we do a tricort-assisted anterior vitrectomy. With the irrigation and the cutting dissociated, the 20-gauge cutter is now introduced into the anterior chamber, and you can see how it cuts the vitreous in the plane of the pupil in the area of the rent. Watch now how we shift into the IA cut mode and then draw out this nuclear epinuclear sheet into the center and aspirate it. Prior to swapping hands to change the vitrectomy on the right side, one needs to perform a viscofluid exchange. Performing a viscofluid exchange prevents further herniation of the vitreous. Having done so, we now proceed to complete the aspiration of the nuclear epinuclear sheet. The cortex can also be removed just with the aspiration mode of the vitrectomy cutter itself. Following the completion of the cortex wash, once more we perform a viscofluid exchange. We now proceed to convert the tear in the posterior capsule to a stable one. We do so by holding on to the ragged tear in the posterior capsule with the help of an intraocular forceps and converting it into a stable opening. Having been successful in converting the opening in the posterior capsule to a stable one, we now proceed to implanting a single-piece monofocal IOL carefully within the capsular bag. It is rotated such as the haptics are at right angles to the tear. With the IOL well centered, the excessive viscoelastic is removed, and this is the end result that we have achieved. In the following case, we will see the occurrence of a PCR during IOL insertion. This patient presented to us with a developmental cataract with a significantly dense nucleus sclerosis. The initial steps of the capsular rexes and hydrodissection were uneventful. The nucleus disassembly and emulsification was carried out using the direct chop technique. The nucleus disassembly was uneventful. The cortex was removed using the coaxial IA, after which a monofocal IOL was implanted in the bag. And here's where the challenge started. Some excessive force was used to draw the trailing haptic within the capsular bag. After washing the viscoelastic from the anterior chamber, the IOL was tilted up and the visco was washed from underneath the IOL. Up to now, everything seems okay. But once this was done, the IOLD Center, and
So, my dear friends and colleagues, if you have any doubts regarding these videos which were played out now, you may